ravaged the world, not the whole world, But God is good. We all survived it. I myself, I'm standing in front of you. I had COVID too, but God was good, I survived it. So I just want to thank God for having today to be a blessing for us. I'm going to call on one of my very important brothers and my in-law to come and give us a prayer. Pastor Femi Oshodi, where are you? Femi Oshodi. Femi. Pastor Femi Oshodi. Hey, where is it? He should come. Femi. Femi, come and pray for us. Pastor Femi Oshodi is resides in Atlanta, Georgia. Came in specially for this. He's my brother-in-law. He's married to my second sister, Olakunle, and he's here always, for the last 3 years. He's going to give us the opening prayer. God bless.
Yeah, it's a pleasure to be here, and I want to welcome everyone to this August event. So shall we stand up to pray? Heavenly Father, we have every cause to be thankful. Lord, this day was set few months back, and you have brought it to a reality. We thank you for as many as can come. We thank you for those who are still coming. I want to thank you especially for the organizers. And we thank you because things were planned and now it's coming to reality. You bringing everything to pass. But as we go into this event, we trust your mighty presence to go before us. We commit the speakers into your hands, Lord, that you will use them to be able to educate us and let us know the modern trends in this topic. Let your name be glorified. Help us to have a good time here, memorable time to go back and come back next year. We give you all the praise as we pray with faith and thanksgiving in Jesus' name. Amen.
Thank you very much, Pastor Femi. God bless you. Well, anyway, we're still waiting for the speakers to arrive. But for now, if you want some tea, there's some tea at the back there, or coffee. You can get something to get you warmed up. I really want to welcome some very good friends who came all the way from America, for this event. I just want to mention my big brother, Dr. Obebe. Please stand to be recognized. He flew in last night and he's going back tonight. Thank you very much. Dr. Amosu, anesthesiologist from Georgia. Dr. Bumi Ogudikwe from California. Where is he? Dr. Buhari Osman is not here yet. No? Okay. That's okay. One of my very good friends, Dr. Bolade Ogun, is supposed to be here. He's not here for some personal reasons, but I need to mention his name. He's been a very big supporter. He's not here now. So anyway, look, I'm not going to say, I can't mention everybody's name. And of course, all the time, the most important person in this room, to me, my wife is there too. That's it. Thank you. Thank you. So I always like to start on time. We're still waiting for the commissioner, and I would hate to start without the governor and the commissioner being here. So if you guys don't mind, can we give them another 5-10 minutes? If they don't start, if they don't come, then we'll start something, okay? The people in America that are watching us, this is my country, this is not even too bad, We're still on time now, okay? But just give us some 5-10 minutes and we can start. Thank you very much, okay? Attention, please, if you don't mind, just for 2 minutes, okay? I did not know the points that I have to bring this up, but I think it's probably appropriate to do this now, okay? Over the last events, I had somebody who was very dear to me and was very close to me, who supported this initiative with all his heart. Unfortunately, he passed on March this year, and I've dedicated this event to his memory. And I just want to let you know that Dr. Olakunle Oni, my very good friend, my brother, who meant a lot to me, passed away this year in February. May his soul rest in peace. If you can get up and give him a moment of silence, I'll appreciate it. Thank you very much. May Kunle Oni's soul rest in peace. And amongst us today, the spouse, Adaoni, Ms. Adaoni, and some of the children are here. Please reach out to her. Ada, where are you? That's Ada. She's there to me. And reach out to her, give her condolences, and God is going to be with you and give you strength in the mighty name of Jesus. Okay?
Close to tears, remember, someday it'll all be over. One day we're gonna get so high. Though it's darker than December, what's ahead is a different color. One day we're gonna get so high. And at the end of the day, remember the days when we were close to the edge, and we wonder how we made it through. And at the end of the day, remember the way we stayed so close till the end. We remember it was me and you, 'cause we are gonna be forever, you and me. Always keep flying high in the sky of love. Don't you think it's time you started doing what we always wanted? One day we're gonna always keep flying high in the sky. As I was walking down path in the woods one day, I came across a vision that caught my eye. There was a lady standing right there beside me. And the vision went away. I thought that I had lost her. Girl, I've been waiting for. I can't believe I just saw her. She's the finest thing I ever could imagine. I want her next to me, cause I want more. Oh, the name is Cinderella, straight to my wishing well. You're the one I'll always cherish. Come to me, my Cinderella, straight to my wishing well. You're the one I love forever. Yes, a gentle flower. She is the sun and wind. She be the reason for my that's all I wish for in my life. Why did she have to go? What do I say to find her? This girl's the only one, I just cannot deny her. She's making love to my mind and I can't forget this feeling. It's her voice that's calling, it's her voice that I need. Oh, the little Cinderella, straight to my wishing well. You're the one I'll always cherish. Come to me, my Cinderella, straight to my wishing well. You're the one I love forever. Oh, Cinderella. Oh, Cinderella. Oh, Cinderella.
Hello, good morning. We're about to start with our first lecture. I kindly request everyone please sit down. I know you're trying to get your cup of coffee. The ushers will definitely come to your table and they will take your order and bring your coffee to you. Please kindly settle down now. Thank you. So in a few moments, we're going to kick off this lecture. And so while we get ready, please get your So I kindly call Dr. Olubawale up here. We're about to start. Please kindly sit down. The ushers will come to you and they will bring you a cup of coffee. Thank you.
Hello. Please, the gentlemen and ladies at the back there, please could you take your seats so we can start? They can come and serve you your tea. The youth corpers, please, sit down, please. So, well, anyway, luckily the commissioner has arrived, and I think it's going to be a good idea to just wait for him so that he'll be the one to kick off this ceremony. Okay? So, I know we're all getting to know each other, trying to relax, and unwind, but it would be very nice if you are settled before you come to. Okay? Please, can we all sit down, please? We We've seen the panel of speakers that we've been able to assemble, and these are very seasoned panelists. So we'll ask you to get your questions ready. It's going to be a very educating session. So your questions, get them ready so that at least you can have something to talk about. So the main theme, like you said, as you can see on the program, is about the pandemic and one particular emerging infection, the monkeypox, that we're going to be talking about. And we're glad. You see, when God wants to promote you, He promotes you in many ways. Professor Shade Ogushola, is one of our speakers. And between the time and now that she's going to be speaking with us, she's spoken, 2 times before. She's just been elevated to the post of Vice Chancellor of the University of Lagos. She's not here yet, but we're going to have the Vice Chancellor in our midst who's going to be talking for us. So we're just waiting for the commissioner so we can start, please. Is everybody okay? They're all comfortable? That's good. So anytime that you feel that you want to use the restroom is at the back there. Those are housekeeping things, But I like us to maintain some silence throughout the lecture so that the people watching us from abroad will know that we're very disciplined set of people in Nigeria, okay? I'd like to recognize some of my boys. We are like a fraternity, Government College Battle. Wherever we are, we recognize ourselves and we give ourselves the due. They've been ardent supporters. For me, I was at Government College Battle 1972 to 1978, and some of my classmates and GCI boys are here. So if you went to GCI or you are married to a GCI old boy, you will be a young girl. Just stand up to be recognized. I'm not going to call your name. Government College Battle, stand up to be recognized, please. Government College Battle. Thank you, thank you, thank you. Look at them. Thank you, thank you. Also, your support over the years. Thank you, thank you, thank you. Well, I went to the College of Medicine, University of Lagos. We have a very interesting forum, very active. A lot of us are here too. I was at Youth, 1978 to 1983. If you went to Louth, please stand up to recognize you. You're my classmates. Please stand up to recognize. We thank you very much for everything you've done for us over the years. Omadele, did you go to your Louth? Please recognize. Yeah, thank you, thank you, thank you. They're all professors, professor of dermatology, professor of pathology. We're all accomplished people. We're waiting, please. Anyway, it might not be a bad idea to just keep on, to start reading Professor Abaya's biography. He's not here, but at least we can start, so that at least when he comes in, we all know him, so there's no point reading this in front of him. Okay? Anyway, Professor Abaya's is going to be our first speaker today. Professor Akpan-Iquot is a specialist in internal medicine. Oh, wow, he's just coming in. Thank you, Professor. Yeah. Okay. So let me just keep on going. Professor Ikeja is actually representing the governor today. The governor has not been able to come, but he's doing a dual role. He's the Commissioner of Health, and he's representing the governor today. Professor Ikeja is a specialist in internal medicine, hematology and oncology, biosecurity and environmental health. He received his first degree in medicine at the Royal Medical College of St. Bartholomew's Hospital, University of London, with fellowship from both Royal College of Medicine and Pathology in the United Kingdom and the College of Medicine, South Africa. His focus has been mainly on the concept of emerging infectious disease and development of diagnostic and clinical capacity in Africa. Professor Abayomi was chief pathologist and head of the division of hematology at the University of Stellenbosch, Faculty of Medicine Science, in 2009, Cape Town, South Africa. Prior to today, he was a consultant at the University of West Indies and University of Zimbabwe. He has been exposed to a vast variety of geographical variation disease patterns within the field of internal medicine, having worked in diverse countries of the world. Professor Abayomi is a fellow of the African Academy of Science. Professor Ikeja Abayomi is the founder of the Global Emerging Pathogen Consortium, also known as GET, which was entrenched as the peak of Ebola outbreak to address biosecurity concerns in Africa. He's a member of the board and honorary professor to the Center for Biosecurity Study, University of West Indies, Cape Verde Campus, Barbados, Caribbean, 2018, as well as professor of medicine and the Institute of Medical Research in Lagos. He's a consultant to the West African Health Organization, Biosecurity, and that's about it. It's very interesting. This is very coincidental that the Commissioner of Health in Lagos State will be an infectious disease person that's very interested in infectious disease. This is good. My specialty can never be minimized. I mean, this gentleman did a fantastic job in Lagos State, controlling and making sure that the COVID pandemic was well contained. And this gained national recognition. It deserves to be recognized and it deserves to be honored. Professor Ikeja Abayomi, come and give us how you did the magic in Lagos State. Thank you. Well, we also have the Permanent Secretary of the Ministry of Health, Dr. Olakunle Oni. Where is he? Who is here to support the Commissioner? Thank you.
Good morning, everybody. So we've had to do a little rejigging of the protocol because Dr. Boye was supposed to be representing the governor. And Dr. Boye is the permanent secretary of the Ministry of Health. I don't think they knew that I was coming to this conference. Otherwise, Mr. Governor's protocol would have done it differently. But I said to Dr. Boye, I said, it's okay. You can be the governor this morning. And I will apply due protocol and courtesy. But he said, no. Since you're here, I should represent the governor. And I said, you're not a very adventurous man. We could have created a stir unheard of in Lagos. But anyway, Dr. Boye, the permanent secretary of the One Health family in Lagos State, thank you very much for gracing this occasion. The MD and CEO of Global Infectious Disease Initiative and convener of this conference, Dr. Folarin Oluboale. And I must say, Folarin, May I call you for line? I don't know how old you are. Are we same age or? Okay. This gray hair is misleading. I'm not that old. I have never met a more determined human being in my life. And there is nobody in Lagos that didn't call me about this conference. Says, are you coming? Are you coming? Are you coming? At one point I had to go and Google Dr. Olakunle and find out who exactly is this most determined, infatigable professional. And actually, because I'm not supposed to be in Lagos today, I'm supposed to be in Holland. So, because of the pressure that was applied on me, I had to change my flight because I couldn't say no to about 30 people that have called me to make sure I was here. Thank you very much to your wife, pharmacist Folashade Oluboale. Thank you for supporting your husband. The Vice Chancellor of the University of Lagos, Professor Shade Ogunshola. Is she here? Ah. Did you just come in? Okay, wow. Thank you very much. Congratulations. I think everybody should get up and say congratulations to Shade. So, most of you may not know, but Shade and I started life together in kindergarten in a small convent school in Ibadan called Mary Hill. And remember, we used to hold hands on our way to assembly with our water bottle around our neck in our little uniforms. But one thing about Shade was always coming first. It was annoying. We just could not get her off that number one pedestal from kindergarten to Form 6. Anyway, she used to be called Shade Mabobuje. So Shade Ogunshola, the first female vice chancellor. And I'm so proud to be her friend. The head of the infectious disease facility within the College of Medicine of Unilag, Dr. Akase, thank you very much. Dr. Akase was one of our commanders in the fight against COVID in Lagos. We really appreciate the expertise, the knowledge, and the tireless effort that you put into the Lagos State COVID response. I'd like to welcome all the other speakers joining us online, wherever you are. Hi. Distinguished members of the health family across the world, partners and stakeholders, ladies and gentlemen of the press, thank you very much for inviting me to this very nicely laid out conference. And I'm very happy to see a whole bunch of youth coppers at the back. Hi. Are you all doctors or associated with the medical? Okay, I like that to see. Thank you for inviting the next generation. So I was asked to speak about the Lagos strategy. So can I have my slides, please? Okay, who's somebody managing the? Okay, next slide, please. So one thing we have in Africa, and I don't know whether that's a consequence of governance or what, but We're having significant rural to urban migration, coupled with high fertility rates, not necessarily in Lagos, but in Africa. And so Africa is going to become a continent of megacities. And we see that already evolving across West Africa and the rest of the other regions. Places like Lagos, Accra, Abidjan, Nairobi, Johannesburg, Cairo. Now these are huge cities. And when you have populations, and the last I heard is Lagos population has moved from 25 million to 30 million. And when you talk to environmentologists or conservation experts or ecology experts, they tell you that land has a carrying capacity, and a capacity with which it can protect itself by recycling the toxicity of human footprint. But it comes to a point, and they'll tell you that maybe Lagos has a carrying capacity of 12 million people. If you exceed that, then the environment is unable to repair itself, because we're overwhelming the ecosystem with human footprint and human toxicity. So we suspect that these megacities are going to become very vulnerable to biological shocks. And what we have been trying to do in Lagos is to make Lagos resilient to these kinds of events. Next slide, please. So what is the role of government? So on the left hand, you need government to understand what I just said and appreciate the trends across the world. The government has to prepare strategically, and it needs to build capacity to respond. But first to predict and then to respond. And then after responding, to ensure that the city or the country or the state is able to recover. And in recovering, that you've learnt some lessons. And so to be able to do that on the right, you need health personnel. You need specially trained professionals that know how to manage pathogens of high consequence. You need the appropriate infrastructure. And that's something I'll talk about in a minute. You need public education. You need the right governance structure, laws, policies, and guidelines. And you need serious research capabilities and ideally the ability to carry out clinical trials. Next slide, please. So what we've done in Lagos, and this happened during the time of Dr. Jide Idris, my predecessor, was we conceptualized the Lagos State Biosecurity Governance Council. And you can see on this Governance Council, and you can see the Permanent Secretary up there. You can see Shade Ogunshola to the right. You can see many prominent members of community. And a mix of lawyers, academics, community, and government. And the role of this council was to advise government on how to manage the biosecurity and bioeconomy of Lagos State. Next slide, please. So our response to COVID-19 was hinged on 5 pillars or principles: anticipation, mitigation. So under anticipation, it was important for us to listen to the WHO and to listen to the organizations that deal with existential threats and there are many. And before COVID, they had actually predicted that the world was going to hit with a pandemic somewhere around 2019, 2020. Nobody knew about COVID, or there might be some cynics amongst conspiracy theorists amongst us who would say that, yeah, the prediction was in line with the plan. But there is no hard evidence for that at the moment. Mitigation is to build that resilience. Adaptation, the ability of Lagos or any environment to absorb the shock, and then after the shock, to ensure that you learn some lessons and you use those learning points to strengthen your system. Next slide, please. And so this is the nature of pandemics. Historically, you have your first wave, your second wave, your third wave, and so on. And depending on what happens, either naturally or by medical intervention, the waves should get smaller and smaller and eventually should peter out as you develop either herd immunity or you wipe out the vulnerable in that environment. Next slide. So this is exactly what government needs to do. So either in reality or hypothetically, the gray peak there, or the gray mountain there, is either an experience you've had as a community, or that you're astute enough to observe what's happening around the world. Professor Gumbi, good morning, sir. Did you just sneak in? Oh, I'm sorry I didn't recognize you. That's another classmate of mine. So can you see from where you are? Yeah, sure. Okay. So what we did in Lagos was we had the experience of Ebola. And there are people in this room that were around and fighting during Ebola. And after Ebola, we realized that we have some serious problems in Lagos. And thank God we were able to bring Ebola under control, much to the sacrifices that some people had to pay, and some people paid those sacrifices with their lives. But we in Lagos said, if we managed to survive Ebola and got hit by something else afterwards and were not able to respond, they would have said, shame on you. And so we took the Ebola experience extremely seriously. And from 2015, we started to build capacity based on our understanding of our gaps and our weaknesses during Ebola. So we started to build health personnel. We started to train on how to manage pathogens of high consequence. And one thing we noticed during Ebola is we had no infrastructure to manage patients that were coming down with highly infectious and dangerous pathogens. People were actually scared. And it's not my responsibility as Commissioner of Health to send troops into the field without appropriate training. I mean, why would you do that? You have to understand what your enemy is, and you have to equip your troops with the right capabilities to overcome the enemy. So we're talking about appropriate infrastructure. We needed laws, policies, and guidelines. We needed a risk communication strategy. We needed to build research capabilities and develop clinical trials. And that's exactly what we were doing for about 4 years when COVID hit and there was a declaration of an outbreak in Lagos. So, in between, you see, we're talking about peacetime and we're talking about war. So you don't prepare for war in war. You prepare for war in peace. Because when war comes, you don't have time. So that space between outbreaks is your peacetime, it's your time for preparation. Next slide, please. So, one thing we did very well, and thank you very much to Professor Ogunshola and other eminent academics in Lagos State, was we built a very robust research environment that interrogated COVID across all dynamics and parameters. And I think that the publication list is now up to about 40, only on COVID in Lagos State. Between Professor Ogunshola and Professor Oshiboki and the rest of the professors of infectious disease and researchers in Lagos State, they did a phenomenal job at helping us to understand the indigenous and natural history of COVID in this environment, not cut and paste. Because if we had cut and paste, we would have squandered our budget just relying and reading about what was happening in Europe and America. And that's not what we needed in Lagos. Next slide, please. And so if you introduce all those elements I was talking about in a pandemic, you're going to flatten the curve naturally because you have the equipment now to respond, and you're not there like sitting ducks waiting for this pathogen to consume you. And the difference between the red bar and the green bar is thousands, if not millions of lives saved. And there are probably millions of people walking around now in Lagos and in Nigeria, thankfully, because of the preparation that Lagos and the rest of Nigeria put in place during COVID. Next slide, please. And so we talk about this famous flattening the curve. And that's ideally what should happen. Because during a biological shock, you have what's called a surge. And a surge is like a tsunami of sick people surging upon your medical infrastructure and overwhelming it such that you can't cope. And that's why you saw pictures of people in India and in Brazil dying on the streets because they had overwhelmed the country's ability to respond to a surge. So the red bar is the surge, and the green represents where you have introduced your mitigating factors to flatten the curve and to bring the surge under the bar. That broken line there is your bar. And that bar represents your ability to cope with sudden surge of sick people. But one thing I want you to notice on this slide is that that bar is not flat. Notice that there is a gradient on the bar. And that reflects learning. It reflects adaptation. And so with every month in the outbreak in Lagos, our bar was rising. In other words, we were increasing our capacity to absorb sick people into our facilities. And that is a good indication of the learning and adaptation that was built into the system. Next slide, please. Press again. So, keep going. Again. So there are different, no, go back. there are different levels of application of your interventions. If you do nothing, you will have a red bar. If you do halfway, you'll get a light green bar. And if you are really serious, you will bring your bar right down and you will diminish the size and the amplitude of subsequent waves in your environment. And so an aggressive early response will give you a green curve. And like in Europe, where they were a bit lackadaisical about their response, they probably got a light green bar, if not a red bar, right? Because they just never thought that COVID was going to shake them the way it did. But we're accustomed to pathogens of high consequence in Africa. We are a little bit more respectful of these very dangerous pathogens that are lurking around in our environment. Next slide, please. And so this represents the Lagos State's roadmap. Essentially, we built infrastructure, we trained staff, we set in place policies and guidelines. We were talking about Agent X, and everyone asked us, what is Agent X? What the hell are you talking about? In fact, people thought, and the people in this room who were with us, myself, Dr. Jide Idris, and many people in this room. Where is Dr. Abdul Salam? Yeah, and Dr. Matiu, Dr. Saka, many people in this room I can see who were involved in this training program were expecting this Agent X. And why was it called Agent X? X means unknown, new pathogen or novel pathogen. And WHO was very clear about the fact that we were going to experience an Agent X imminently. And so we in Lagos took it very seriously. And we planned for Agent X. Next slide. And what we did was to set up an incident command structure, which you're all familiar with. It's actually a system that takes on a military-style strategic planning profile, because when you're going to be hit by something that's going to cripple your economy and destabilize your security, you need to escalate it to the highest level of authority. And so an emergency operation center is okay as an arm of the incident command structure. And it's okay for small outbreaks like cholera or a small flu outbreak or a couple of monkeypox cases or flu, but it's not enough for a pandemic where thousands and millions of people are going to get sick and where the business of governance is going to stop. So you need something that has lots of teeth, and that was why Mr. Governor is the incident commander of the incident command structure. And that makes it actually very easy for you to pass laws, for you to make dynamic changes, and for you to gain access to resources in the flash of an eyelid. In COVID or pandemics, you don't have time to write memos and wait for approval and wait for it to go through the normal bureaucratic processes that can take weeks or months. You literally have hours to make decisions and implement changes. So that's the structure of our incident command system. It's very, very dynamic. It's very flexible. It brings in everybody. It brings in the private sector. It brings in the donors. It brings in all kinds of partners, but it ensures that the government is in charge of this biosecurity threat that is currently being experienced. Next slide. And so we did a lot of scenario building. The first scenario was that COVID was going to bypass Lagos and we're not going to have any problem. Scenario one. Of course, that soon disappeared. And there's no reason to actually believe that scenario 1 was realistic. Around December of 2019, we could see that this pathogen was moving systematically across the world. Scenario 2 was that Lagos was going to experience a small outbreak, but rapidly bring it under control. And we will just have to do 1 or 2 things to adjust life in Lagos. But scenario 3 was our most likely situation, where there's going to be a large, extensive outbreak spreading throughout our slums and high densely populated areas, and the healthcare system was going to be challenged, and 25 million people were going to be more vulnerable, and we were going to experience multiple waves. And so we were riding on the back of scenario 3. Next slide. And indeed, that is exactly what happened. The first wave in early 2020 was caused by the wild virus from Wuhan. The second wave was Alpha. It was bigger than the first wave. The third wave was Delta. And even though Delta was seemingly smaller than Alpha, it was more lethal. We had a lot more sick people in the Delta wave. Our isolation centers were packed to the brim. We almost came close to running out of oxygen. It was literally, and I remember almost getting on my knees and saying, no, we can't take any more cases now, otherwise people are going to start dying in the streets, because people would be getting into our isolation facilities, and we literally would not have enough oxygen, because that was the currency of survival during the third wave, oxygen. And then our fourth wave was Omicron around Christmas, and then we now had the fifth wave, which is another variant of Omicron. And dare I say that we might experience a sixth wave this Christmas. But we're still looking at the modeling. So what did we do in each wave? First wave, remember the law was everybody positive needs to be isolated. And as our numbers started to increase and we're diagnosing 300, 400, 500 people a day, the question was, where were we going to put all these people? And we were building isolation centers as fast as we could. And they were costing an arm and a leg. And during the course of the first wave, we soon realized that, well, hang on a minute. Everybody in isolation was not sick. Only a handful was sick. Everybody else was literally either having a party, enjoying our free food, or complaining bitterly at being confined for no reason. Well, it was the first wave. We really didn't understand what was going on. Our research team kicked in, and soon we started to understand that the natural history of COVID in Lagos was not the same as the profile in Europe and America. So we had to say, okay, we need to re-strategize here. And so what we did was to introduce a triaging of patients and suggest to the federal government that we were going to manage COVID in community. Now you can imagine that didn't go down well at all. People thought, this Lagos has come again. But it was an imperative. There was nothing else we could do. Dr. Ikeja remembers we were diagnosing 500 people a day. And if the instruction was isolate 500 people a day, we were renting hotels, we were going to schools. Any possible space was turned into an isolation facility. But we needed the manpower as well, the logistics. And let me tell you, managing COVID is 90% logistics. That's what it is, logistics, structure and order. Anyway, we went through, we started to manage patients at home. We, of course, built our oxygen capacity. We started to install oxygen plants. We introduced vaccination. And of course, in the fifth wave, we started to introduce genomic sequencing so that we can identify what waves are coming in, what pathogens were coming in, and whether we ourselves were evolving any pathogens in our environment. And indeed, we did evolve one pathogen. Maybe you may not know about it. It's called the Eta variant, which emerged somewhere in Lagos or somewhere in Nigeria, but certainly we picked it up in Lagos. Next slide, please. And so this is some of the stuff we did. The top left-hand corner is the Lagos State Biobank that we have been busy building for about 4 years, collaborating with international partners, South Africa and Canada. And this biobank was designed by Lagos in collaboration with our partners. It's a very sophisticated facility and it is totally off-grid. So you see the roof is all solar panels and it has 4 backup supplies of power so that at no point in time is there no power in this facility. And of course you can see all the isolation facilities that we built in collaboration with the private sector, preparing for the surge across the 4 or 5 waves that we had. Next slide, please. And what we did, the Lagos State response was based on data. And every day, the Lagos State Biobank, which was the nerve center of the COVID-19 response, would send me data by about 10 o'clock in the night, the data for the day, number of cases diagnosed, number of patients admitted, number of patients dying, and all the other ancillary data. And that data would go to what's called the Incident Command War Room, which Mr. Governor set up. The data would get to Mr. Governor and the War Room by about midnight. By 1 o'clock in the morning, the data will be discussed. Sometimes those discussions could go until about 2 or 3 in the morning. And if there was any change in policy, the policy would be changed by 8 o'clock in the morning. And that was the flexibility and the dynamic nature of how Lagos was able to respond on data. And you cannot have an effective response without real-time data. Next slide, please. And so this is something like what our dashboard looked like every day. The data would come in and would upgrade the dashboard, and this is the kind of information that the incident command structure and the war room would process, and decisions would be made based on the size and amplitude of the surge and the complications arising from the surge. Next slide, please. So with the other thing we did was to build, to decentralize access to oxygen. So one of the things we noticed, and it was probably the cause of most of the deaths that we experienced in Lagos, and we only had about 800 deaths altogether. In the entire COVID 5 waves, 800 deaths. I mean, of course, we're not happy with any death, but there were countries that were having 800 deaths per day. And we managed to keep our deaths under 1,000 throughout the entire 5 waves of COVID response in Lagos. But one of the things that was causing people to die was access to oxygen. And depending on where they were, trying to get to IDH or any of our isolation centers was a problem. They're either stuck in traffic, by the time they get there, or they get to other facilities, those facilities would turn them away because they were not COVID facilities. And they couldn't risk bringing a COVID patient into their facilities, otherwise they would contaminate the entire facility. And remember, in Lagos, we had cordoned off COVID response from the rest of medical treatment. We had to separate them. Otherwise, there would have been significant collateral damage from incapacitating our entire health repertoire of facilities, focusing them on COVID. So we identified just a few facilities that would respond to COVID and made sure that the rest of our facilities were addressing day-to-day medical attention. Because in COVID, if you divert all your resources to a pandemic, then you get deaths from other conditions. And so your collateral death rate may even exceed the deaths from your pandemic. So we started to build these 10 of them, oxygen centers and triad centers in decentralized locations in Lagos, so that people could come to these facilities, get oxygen, get stabilized for a day or two, and then move slides. And so these decentralized oxygen facilities were specially designed, open air, nicely ventilated, as you can see. People would come out there onto the balcony, they would come to be tested, they would receive their oxygen, and inside is that room to the right there is where, if you needed to be put on oxygen and kept there for a few hours till you're stabilized, and then we can move them. But we designed them in such a way, knowing that COVID would soon be over, and that we could repurpose these facilities and use them for something else. Right now, these facilities, the 10 of them, at least 7 of them have already been repurposed. One is an accident and emergency, one is being used for sickle cell and obstetrics, or all kinds of things. So these were designed in a way that we're not wasting money on COVID infrastructure, but we were spending money on infrastructure that could be repurposed after COVID. Next slide, please. These are just our oxygen plants. We installed and assembled 3 oxygen plants in Lagos to make sure that we could raise our oxygen capacity. And certainly, if there's one thing I remember in each peak of every wave, is the unmistakable sound of clanging oxygen cylinders. If you walked into any of our isolation facilities during a wave, all you hear is the sound of oxygen cylinders being moved and carried away, and it's a very unmistakable sound. And those of you that know that sound, you know what I'm talking about. Next slide. Okay, so how did we enforce the pandemic laws? So we wrote 2 laws during the COVID outbreak. And the laws, because you couldn't enforce a guideline if it's not backed up by a law. So if somebody was diagnosed with COVID and he said, you need to stay at home for 7 days, and they refuse to obey you, what are you going to do? If you don't have a law, you can't enforce it. So we had to write the laws. And we wrote the laws very quickly. And that gave the government the power to enforce the biosecurity protocols that we had established. So if we say test on day 3 and test on day 7, we will first alert you, we will call you, we will alert you, you are overdue for your test, or you are found moving around when you should be in isolation. This is your first warning. You are due for a day 7 test. If you don't do it, we will send you somebody to come and collect you and bring you to where you will face the magistrate and receive your sanctions. So that's what we did. Next slide. That's the mobile court. And we used a track and trace to identify people that were disobeying the public health laws of COVID. We used security agencies to track down individuals, and we brought them to our mobile courts, and we enforced the law with very gentle sanctions, but it worked. Next slide, please. And these are some of the infractions and offenses that people were tried summarily at these mobile courts. Next slide, please. So, for example, how did that law impact or flatten the curve? In this slide, you can see that the blue bar represents the number of people that were testing per day. And when we said you need to test on day 3 and day 7, people were traveling and they wouldn't go for their tests. And then we said, with the red bar, that if you don't do your test on day 3 or day 7, we're going to come and collect you. And you can see immediately the testing went up to 6,000 per day. And what was the impact of that? Let's see the next graph. You see where the blue line is going up? As soon as we introduced the announcement that we are going to sanction you at the mobile courts, the graph flattened and then eventually came down. So what does that mean? It means that more people were coming for testing. We were identifying more positive people. And when you know you're positive, if you are a civil member of society, you would at least isolate yourself at home or reduce your contact with other individuals, particularly our elderly and vulnerable. And I believe that that's exactly what happened. That when people knew what their status was, by virtue of being tested and compelled to be tested by the law, that people became a little bit more careful about their movement, knowing that they were positive. If you have a conscience, you wouldn't want to go out and infect other people, particularly your loved ones. So the law works, and the application of the law is here clearly demonstrating that by enforcement you can flatten your curve by making people a little bit more astute to the implications of our guidelines. Next slide, please. One thing that we did during COVID is we noticed that we were collecting huge amounts of data, and we didn't have the regulatory framework for managing that volume of data. In fact, we didn't have the regulatory framework for managing data, full stop. And so we quickly had to go to NITDA, which is the Nigerian Institute for Technological Development, and they have something called the Nigerian Data Protection Regulation. And anybody who is managing public data, by law, you need to be compliant with NDPR, because there are two types of sensitive data, human-related data. There is your financial data, and there is your health data. And I don't think any one of us wants either our financial data or our health data to be hacked or accessed without authority. And so we had to put in Nigerian Data Protection Regulation compliance. It took us about 9 months to do this, but I think that's what they tell us, that the Ministry of Health in Lagos is the first government agency to be declared NDPR compliant in Nigeria. Thank you. Next slide, please. So I'm almost at the end. Strategies we deployed. Number one, we included the private sector. Number two, we decentralized sample collection. Number three, we included the private laboratories to increase our capacity. Number four, we strengthened home-based care. We maintained our capacity, continuously building. We enforced our guidelines and our non-pharmaceutical interventions, and that created a virtuous cycle. And at the end of the day, next slide, please. Okay, I'll talk to that in a minute. This is our gene sequencing suite that we've just acquired at the Lagos State Biobank, and there are people in this room who are working in this genomic laboratory, where we now have the capacity to sequence the COVID-19, and we've had about 5 runs of sequencing so far, which is giving us some very interesting data. So we're able to pick up what the variants are in Lagos and to also identify variants that are circulating in our own environment. Next slide. And one of the things we did during COVID, and I think that that is what Lagosians were very grateful for, was that Mr. Governor insisted on continuous and constant communication with the public to calm everybody down and to make sure that everybody understands that the incident command structure was working very hard, and that we were going to do everything in our power to ensure that we maintain lives and livelihood. Next slide, please. And so what is the future? Having seen what happened during Ebola, which caused us to prepare for COVID, we've now seen what's happened in COVID, and we realize that we need something bigger. And so we've already conceptualized that something bigger. It's called the Lagos State Infectious Disease Research Institute. It's almost at its stage of completion of its design. We already have mapped out the location in the IDH. Next slide. That is what it looks like from an aerial view. Again, it's a very professional design. Its carbon footprint is 50% lower. So its running costs will be very, very low compared to a conventional building. It has renewable energy all over it, and it is an institute. If you show me the next slide, please. This is what the inside will look like. It's a place where we will attract or initiate research into infectious diseases. We will attract international collaboration. It is a place where people can come and spend 3 months, 6 months, 9 months from all over the world looking at infectious disease agents that are causing problems or possibly going to cause problems for us in Lagos or Nigeria. And it is really our next initiative, and we're going to break ground in the next 2 or 3 months to start building this iconic building, which we believe is going to continue to make Lagos resilient to the importation or the emergence of these dangerous pathogens. And since Lagos is the entry to Nigeria, it's important that this facility is located in Lagos and can protect the rest of Nigeria. This is just to show you the complexity of the air systems that will be in this facility to make sure that the laboratories are BSL-2, BSL-3, and a BSL-4. Next slide. And you see the complexity of the biotechnology, and those of you that are involved with this biosafety facilities, next slide, know what all this means. And those are the air systems filtration that make sure that the people that are working in that facility are safe and that we're not discharging dangerous pathogens into the environment. This is just a bird's eye view of IDH, our mainland hospital, our institute, our infectious disease hospital. And that's where, in blue, with the blue top there, that's where the IDRI is going to be located. So in conclusion, our approach to managing COVID-19 can be summed up as follows. We learned from Ebola, and we learned from observing what was happening around the world. We used empirical data for decision making. We incorporated a lot of indigenous research to understand the natural history of COVID in Lagos and Nigeria. We put in place a system that was dynamic, flexible, and swift. We used real data, and very importantly, we engaged with intellectuals in Lagos, in Nigeria, and across the world to define a pathway for the Lagos State response. Now, the job of government, as I said, is to be able to predict, respond, bring a threat under control, and learn. Under the response, it is important that we follow the tripod of pandemic mitigation strategy. And the tripod is based on three things. The first thing is the public health response to the outbreak. The second thing is the ensuring that the pandemic does not cripple the economy of Lagos. And the third thing is to ensure that peace and security prevails. Otherwise, you might find that if your public health response is too heavy, it will trigger an economic collapse. And if you have an economic collapse, you will certainly trigger a breakdown in law and order. And so government's job is to find that delicate balance between the public health response, ensuring that the economy of the state is protected, and that we do not fall into a security issue. And I think COVID has shown the world the nexus and the relationship between health security, economic security, and national security. And we learned very quickly in Lagos that if your public health response is too heavy, you're actually going to get more casualties from economic collapse and breakdown in law and order. And so it's important, yes, we are doctors and we're here to bring an outbreak under control, but what is the business of the cabinet? The business of cabinet is not necessarily bringing the outbreak under control, and this is a hard pill to swallow for medical personnel. The business of government is to maintain livelihoods, peace, and security. And so in there, you have to measure your public health response to make sure that you don't cause a loss of economic viability and a breakdown of law and order. Next slide, please. Next slide. Oh, that's the end. Thank you very much.
Wow, what a fantastic job. Professor, I must tell you I'm very proud of you, or your government, and your ministry. Do you see what happens when you put a round peg in a round hole? Can it be better? Aren't you proud to be a Nigerian? Me, I'm proud. Those of you watching me in America, you see my country. Nigeria doesn't carry last. We are not going to carry last. I'm so proud of you. So we're going to have some questions because he has to leave, okay? And he's giving a lot of his time to be here. So just for 5-10 minutes, we're going to have questions, and we're going to actually adjust the program. There's a speaker from America that's going to join us, via Zoom before Dr. Akese speaks. So do you have the microphone to give to people who want to talk? Yeah. If you have any question for the professor, please make it short and sweet, okay? So he can answer your questions, okay? Anybody? There's a professor here.
Thank you, Professor Abayomi. My name is Olajin Ramosu. I actually have quite a few questions, but I'll just limit myself to two. Number one is that given having seen COVID up close and personal, I don't think it's we can, and knowing the mortality in Nigeria and the mortality in the West, I don't think we can begin to say the response in Lagos vis-a-vis isolation centers and whatever we've done is responsible for why we have a tenfold, death rate in the developed world. Is Africa, hopefully led by Lagos, trying to answer this question for the rest of the world? Is that something we can give back? That okay, this is what is in our people that didn't let them die as much, and therefore maybe if we can replicate that, for the rest of the world, is that something we can give back? My second question will be, I think it was Churchill, that said, never let a crisis go to waste. And in the case of Nigeria, what have we gained from the fact that, we got struck with COVID? Do we have a lot more ICU beds, available in the country if we were to be, if we were to get stricken by another pandemic that requires, those sort of intensive facilities. Thank you very much.
Okay, thank you very much. So, there are two ways to answer that first question. We do believe that there is a protective effect in our environment, but there's no doubt, and those people, and there are many of them in this room, from permanent secretary all the way down to people that were working in the laboratories, there is no doubt whatsoever that Lagos preparation saved thousands and thousands of lives, because we saw them. It's not hypothetical. They were coming into the facilities and they were extremely unwell, and if they didn't have access to the treatment, they would have died. So we probably, and we understood this clearly, and that's why I said our research showed that there's a different natural history in Lagos or in this part of the world. What we're doing now, and we're just developing the protocol, is to look at, we have all the samples in the biobank, and that's the beauty of biobanking, because we can now go back in peacetime and look at the data and the samples. And so we can stratify all patients into at least 4 categories. Those that were asymptomatic, positive asymptomatic, positive mild, positive moderate, and positive severe. And a lot of the severe cases died, but we have the samples. So if we are able to stratify them into those 4 broad categories, and there are more categories, but I'll leave it at 4, we can now go to our genomics laboratory and say, can you interrogate the genome sequence of the patients based on this data and see if you can find any SNPs that correlate with mild disease or death, if you look at the 2 extreme cohorts. And if you see SNPs that are present in the mild cases or absent in the severe cases, then the bioinformaticians of which we're now we've started bioinformatics training in the lab, and the staff are here. And there's some people, I've seen them in the room. One of the biggest gaps we have in Africa is bioinformatics experts. So if any of you have children that are wondering what they need to study, just encourage them to study bioinformatics, because we will pay anything now for a good bioinformatician. So the bioinformatician will be able to interrogate the genomic analysis and come up with SNP reviews that will point towards signaling pathways that we may be able to identify as protective or making you vulnerable to COVID-19 severe disease and death. And inside that, we'll now create an innovation pipeline that can either lead to the discovery of a drug or the discovery of an intervention like a vaccine that is mimicking natural biology. The other thing that it could be is an environmental factor. It could be, some people talk about vitamin D, they talk about other pathogens and cross immunity from things in our environment. Maybe we have something that's similar to COVID-19 circulating and giving us cross immunological reactivity. Maybe it's the food. And caught it several times. And I'm not going to tell you how many times I had COVID. And everybody in this room has seen COVID. Either you know it or you don't know it. Maybe you had an asymptomatic infection. And we know that from our modeling, because our first modeling actually shocked us. When in the first wave, the first model within 2 months told us that 10 million people had caught COVID. And we said, that's not possible. But we soon realized that it was possible because people were getting COVID. But because we have this youth bulge, people were sick, but not sick enough to be admitted. And that's why we were able to manage people at home. But suddenly, some people got very sick and some people died. And many people died at home too, unknown to us. And we saw the sick people and we saw the people that died. And we saw the people that survived. And we also saw the people that were not sick enough to be admitted and were diverted to their homes. And what we've seen over the 5 waves is that we're getting fewer and fewer people getting systematically unwell in the moderate to severe category. And that probably reflects the amount of herd immunity that we have in the community. And that herd immunity is majorly due to natural infection. Although there's a vaccine component, but the herd immunity is the fact that after 5 waves in Lagos, I don't believe that there's anybody in Lagos that has not been infected with COVID. The other question was, what have we learned? So that was the whole emphasis of my presentation, that you can't go through something like Ebola or go through something like COVID and not learn. If that's the case, then that's an irresponsible government. And we are learning, and I've shown you that what we put in place after Ebola, we're exponentially increasing that. Because if COVID actually had 2 or 3% higher mortality than what it actually did, then what we had prepared for would not have been enough. Because a lot more people would have fallen into this moderate to severe category, and the surge would have overwhelmed us, and we would have seen the scenes that we saw in India and Brazil. Now, if you remember that in India, they had a first or second wave that was just as mild as ours. And we all said, oh, well, whatever is protecting them in India is the same thing is protecting us in Africa. Then their third wave came and almost decimated cities. So there was a mutation, probably the Delta, I believe it was the Delta, that was able to overcome the natural resistance of the Indians and cause severe sickness and death. And we're praying that we don't see a variant in Lagos that is overcoming whatever it is that is protecting us from severe to critical disease in this environment. It can happen because the virus is still circulating, and the virus, we're expecting a new surge. And once a virus is circulating, the virus is doing what it knows how to do best. And the virologists are in this room. A virus is always looking for how to overcome your natural defense against it. And so it's mutating combination and permutations to find a way to overcome your natural resistance. And if it finds a mutation that works, that mutation now takes over and becomes the predominant strain causing disease. And it may cause severe sickness and a much more dangerous wave. We hope not, but there's always a possibility. Thank you.
Thank you very much. The questions have to be very limited because, no, just one more question, please, okay? Just one more question.
I think Professor Abayomi has really done a lot. Even during the COVID period, I'm not a medical doctor, but I'm an architect. I don't want to go through what you have said, but I want to answer you a question concerning what will happen after all these great things that you have led Lagos State to achieve. Coming to Lagos presently, as you said, Lagos is like the entrance to Nigeria. We can successfully come to Lagos by air, as most executive people are doing in the country today. They don't go by roads, they go by the air, particularly when you become governors. Coming to Lagos from Ibadan, because we learned that you must keep your health very well during COVID. But we are building slums around us in Lagos every day, even as at now. Coming from Lagos, you can see Kara area, left and right, instead of human being, beautiful things developing. We could see that we can see cows, sheep, people even stay on the road to buy sheep, like this, as if we not traveled before. Because if you are training, I understand in China now, instead of concentrating on hospitals, they are trying to concentrate on nutrition and, of course, prevention, medicine. So less hospitals are being built, while nutrition and environmental re-engineering are going on. Sorry, I'm asking this question because when you start talking, you say you are wearing two caps. You are standing for the governor and you are standing for the commissioner of health in Lagos State. And Lagos is the only place that people come to copy. I know people, governors, that will say they come Lagos to pick some things and repeat it in their states. Please, sir, how are you taking care of the environment so that there won't be these slums that will affect average Nigerians? We look handsome and beautiful during the day. In the evening, a lot of problems we are creating. So, sir, I want to go through you to please take physical development. Density, you said about 30 million people should suffice for Lagos State to stand on it. Otherwise, we may sink into the water. So I think the influx of people to Lagos today is so enormous. So I think you'll be able to enlighten us of how to move forward. Thank you very much.
Okay, thank you. Yeah. So I'm glad that I'm surrounded by the Lagos State COVID-19 or biosecurity team, because this is exactly the issue. The question you've raised is exactly the issue that the team, who are very successful in bringing, at least stopping COVID from. So one thing we say in Lagos, we didn't stop COVID, we just stopped COVID from disrupting our economy. And we protected as many lives as we could. Because if we hadn't protected the economy, we would have lost lives from economic hardship. So that's what we did. But the point you're making is a very, very serious point. And what we say in Lagos is that we are the victims of our own success. Because the better Lagos gets, the more attractive it becomes to everybody. And we are subnational, and so we cannot control inland migration or even migration from neighboring countries. People come straight from wherever to Lagos looking for opportunity. And so that results in slum explosion. And we've done the slum analysis. And when during Ebola, we had about 60 slums. And now we've done our slum analysis, and I'm not going to tell you the figure, okay? Because I don't want you to know. But the people that need to know. But let me just say that it's concerning. So what are we doing? So we've also adopted what we call the One Health strategy. And the One Health strategy essentially says that you, as a human being, we need to look at health holistically. And as a human being, you cannot be healthy in an environment that is unhealthy. You cannot be healthy if you are eating unhealthy food. You cannot be healthy if you are in a stressful environment. And so the One Health paradigm is not an invention of Lagos State. It's actually a WHO paradigm, but nobody's really been taking it seriously. But I must commend the Lagos State Biosecurity Governance Council, because they've taken One Health seriously 5 years ago. And we've been trying to build the One Health strategy in Lagos. And the One Health strategy involves Ministry of Health, Ministry of Environment, Ministry of Agriculture, Ministry of Justice, and Ministry of Physical Planning and Urban Development. Those are the key members of the One Health team. Of course, there are other members, but the main pillars that build the One Health team are those key ministries. Why? It's precisely for what you just said, that if you're thinking that you can protect lives and livelihood in Lagos by focusing on Ministry of Health, you are going to be sincerely shocked at what's going to happen, because you need to protect lives by ensuring the environment is healthy. You need to protect lives by ensuring the food we eat is healthy. You need to protect lives by making sure that Lagosians are not overstressed by virtue of our lack or poor physical planning and making people sit in traffic for 4 or 5 hours, get up at 4 o'clock in the morning and get home at midnight. That is not a quality life. If you live that kind of life, you're going to end up with either mental disorders or hypertension. And so we're taking the slum strategy and the One Health paradigm, because all it requires is for a dangerous pathogen to enter one of our slums, or in fact, it can emanate from one of our slums. And we all know that under the circumstances, nobody is safe. You can think you're living in Ikoyi or VI or Ikeja. It doesn't matter. A dangerous pathogen will find you. And so in the balance of biosecurity, we talk about protecting the larger community and ensuring that we are not allowing dangerous pathogens to brew in our slums, or we're not allowing dangerous pathogens to get into our slums and explode and then come back out and affect everybody in the community. So we are also working on this prevention versus cure strategy by strengthening our primary healthcare structure, ensuring that we move our response into the community rather than focus it in our central institutions. Public health response is at the grassroots level, and therefore we need to build a very robust and strong primary healthcare structure to be able to, first of all, detect and early, and secondly, squash it as fast as possible and ensure that the response is maintained in the community. And so the Lagos State response, everybody thinks it's in IDH. No. IDH is where the nerve center was, but the response actually took place in the community. And there are thousands and thousands of doctors that we here are representing as the executives of the Ministry of Health and the Governance Council, but the real response was carried out by our doctors, nurses, and community health practitioners and volunteers, thousands and thousands of volunteers who were working deep in the community and ensuring that we were able to contain COVID even inside these slums that you're talking about. And that's how it wasn't a central response. It was a central governance, but disseminated to the grassroots level where all the foot soldiers were responsible for carrying out response. So the commendations go to all those foot soldiers at the community facility. Thank you very much for that question.
Okay, thank you very much, Professor, and thank you very much for the questionnaires. This was very good, very stimulating. Actually, I think we can even declare this conference over, because Professor have really hit it out of the ballpark. Well, it's going to be leaving very soon, but the Global Infectious Disease Initiative from the USA is glad to give to you a plaque to recognize the good job you've done for Lagos State and Nigeria, and for putting us on the map of at least being very proactive and containing this epidemic. Look, we appreciate you, and I'm asking you, the next one I'm going to do, let me tell you, it's not easy for me to put this together, okay? Like you've seen, you said I'm a very tenacious person. My friends are here. They know me. For line, it doesn't stop. Buhari Osman is from USA, nephrologist. That's my best friend. Burije, please get up and let me recognize, please. There are people who came to me, came from me, with Columbus, Georgia, because of what they believe in me. Christina is my nurse, Columbus, Georgia, with a brother. Christina, get up and be recognized. She's pregnant, 12 weeks, but she says she's coming to come and be with us in Nigeria. Jonathan, get up, Jonathan. Yeah, that's good, from Columbus, Georgia. Oluyembadero is a cardiologist. He was the first person that was talking about COVID. Oh, that's him, from New York. But anyway, I'm going to give this plaque to you to recognize you, but what I'm just saying is this. Next year that I'm going to do this, or next time I'm going to do this, I pray you're still in government. So when I come to you and say I want to do this again, you've seen what I've done. You know that I'm not a joker. I do things wild, and I bring very important people together. So if I say I'm doing it, do you promise in front of this crowd that you're going to support me?
If I'm still here,
Okay, even if it's only because of this ceremony, Sanwo-Olu is going to be reelected again. Thank you, thank you. Well, on behalf of the, no, we don't need to do that. We don't need to do that. Yeah. On behalf of the Global Infectious Disease Initiative, based in Columbus, Georgia, yeah, take it away. Just take it. Doesn't matter. Based in Columbus, Georgia. What's that? Is that good like that? I'm presenting this plaque to you to recognize your tenacity, your commitment to the field of infectious disease. You've done very well, and anytime you come to the United States of America, my household, with the permission of my wife, will welcome you. Thank you very much. Just take it as a token, okay? God bless you. God bless you. God bless you. Thank you. Thank you. Thank you.
So this is a very beautiful plaque. I love the artistic. I don't have anything that looks like this. I'm going to put this in a special place. But I just want to emphasize that I would like to dedicate this plaque to everybody in the Lagos State government, from the incident commander, His Excellency Mr. Babajide Sanwo-Olu, for being such a good listener and a very fast learner, all the way down to the community health volunteers that were working at the grassroots level, making sure that Lagos was safe. So I dedicate this to them, and also to you, my friend, because you call me tenacious. I think you take the degree for tenacity. Thank you very much.
Thank you. Professor, let me just. My wife just wants to. Professor, can you just let's take a picture of it before he goes? Yes. Like I said, come, Ikeja, come. Let's just take a picture before he goes, okay? Inshallah. And Kushala, of course. That's my wife. Yeah. No, let you hold it now. How do we do it now? Nicely, yeah. Well, thank you very much. I was wondering who you are. I don't like to stand next to tall people.
Just like I bent my manifest to come to this conference, Lagos State is also having their own biosecurity conference on the 2nd of November till the 4th of November. So I hope that those of you that are here in Lagos will come to that conference. It's the 8th African Biosecurity Conference. It happens every year, and Lagos continues to hug it. Although it's been to Accra, it's been to Dakar, it's been to Abuja, but we love it in Lagos because we feel we get a lot of benefit from hosting that conference in Lagos, because it brings the United Nations, WHO, Africa Union to Lagos every year to talk about biosecurity issues. So I will pass the information. If you just, how will they find the link? What's the link? Or you will circulate the flyers? Okay, we'll circulate the flyers here. So those of you that are interested, it's here in Lagos at the Civic Center on the 2nd of November. Please either join physically or join online. Thank you.
Thank you very much, Commissioner. It's been a pleasure meeting you, and we're all very grateful that you created the time to come. Well worth it. I'm very happy you came. Thank you. God bless you and honor you. Well, we need to move forward now because the day is far gone. I'm going to reverse things. We're going to go to the Zoom speaker from the USA because he has to go back to work, you know. So the next speaker is going to be Dr. Mobolaji Ogunshaki, who's a very good friend too, a colleague. Who, yes. Oh, wow. Bolaji is there already. That's good. Mobolaji is also an infectious disease specialist from Columbus, Georgia, Macon, Georgia. He practices there and he's been a very good friend. He's spoken for me at a few of these conferences, and people are always very amazed at the knowledge that this young man has. Very interesting. We have a very interesting relationship. Bolaji was the best man of my best man. Very interesting. So this is a very close guy to me. Bolaji is going to be talking about the experience in the USA we had from the Lagos State. So he's going to give us some lesson that was learned in the USA. Bolaji, thank you very much. Are you ready?
Yes, I am. Can you hear
You
me?
ready?
Can you hear me? Hello, Folari. Hello.
What's that? Speak up for what?
Hello.
What are you talking about?
Hello.
I should speak up.
Can you hear
Hello?
me?
Hello? Can you hear me?
Yes, I can hear you.
I know that now. Okay, Bolaji, fire John, please. Fire on.
Okay. Thank you very much, Folari. Thank you very much. Good morning. I would like to observe protocol. In absentia, His Excellency, the Governor of Lagos State, Babajide Sanwo-Olu, Honorable Commissioner of Health, Professor Akin Abayomi, the Vice Chancellor of University of Lagos, Professor Shade Ogunshola, fellow speakers, eminent guests, distinguished ladies and gentlemen. It is my honor and privilege to be here with you via Zoom from Georgia, USA today. I must say that just like Folari said, Professor Abayomi's talk was the best, and the conference could have closed after he finished. Excuse me. But I would like to share with you a few things that I observed that I think that the world should learn from the ongoing COVID pandemic. First of all, let me seize the opportunity to congratulate my friend and my colleague, Professor Shade Ogunshola, the new Vice Chancellor of the University of Lagos. Shade and I go way back. We were both medical students at the University of Ife, now Obafemi Awolowo University, Great Ife. So we come from humble beginnings and we've come a long way. Congratulations to you, Shade. May you continue to achieve great things. Amen, amen. So this morning, I'm going to share with you some of the lessons to learn from the COVID-19 pandemic. I'm an infectious disease physician in Georgia. The COVID-19 pandemic, in a nutshell, we know that the etiology is the SARS coronavirus 2, severe acute respiratory syndrome coronavirus 2. It originated in Wuhan province in China. And we know that the initial reports of the outbreak were released in December 2019, and it rapidly spread to all continents of the world. We know that it causes severe respiratory symptoms, spread to person, airborne spread. As a result of this, new vaccine technology has been produced. We have the mRNA and the DNA vaccines, and we have vaccine schedules, primary series, booster shots, and boosted vaccines, targeted booster vaccines. We have drug treatments, antivirals, we have remdesivir, and we have Paxlovid, which is nirmatrelvir and Norvir. And we have emerging muted variants. That, in a nutshell, sums up what the pandemic has done in the last 2.5 years. So this is the third year of the COVID pandemic, and we're seeing pandemic surges, just like Professor Akpan-Iquot alluded to. Right now, we have the highly infectious Omicron subvariants, BA4 and BA5, which are capable of partial immune system evasion, which means that whatever immunity that you achieve from a previous infection or from previous vaccination, these subvariants have the ability to circumvent it. So we have continued ongoing viral transmission. And as a result of that, we have continued viral mutation. As the virus is transmitted, as it replicates in the host, it undergoes mutation. And that's what causes these subvariants to emerge. Vaccines were developed, but there has been inadequate COVID vaccine deployment and uptake, both abroad and even here in Nigeria. So there are still abundant susceptible hosts. That's why the pandemic continues. The virus is still finding a lot of people that it can infect. And also, we have to contend with waning post-infection and post-vaccination immunity. When somebody gets infected, after a few months, 6 months, the immunity that was generated by that infection starts to wane. And then after vaccination, after 6 months, the immunity starts to wane also. So it's most likely that we're going to have future COVID-19 pandemic transitioning to endemic situation. That means that instead of worldwide ongoing infection and surges, sooner or later, we're going to transition to an endemic situation where the virus occurs locally in certain areas and occurs recurrently, almost like a flu every year. So the successive variant waves of COVID-19, they seem to be always one step ahead of the vaccines. So when the mRNA vaccine was developed, we thought that, oh, the pandemic is over. Only did we find that the virus had developed the ability to be resistant to the immunity, the antibodies produced by that vaccine. And it's the same thing that is going on. As we improve the vaccines, the virus is mutating and staying one step ahead of us. We'll talk about this later. So to give some numbers, when I put this talk together in September, by September 23rd, 2022, there had been 611,421,786 confirmed COVID-19 cases and 6,512,438 deaths, as at that time in September. As of yesterday, that number has increased significantly. We have now had 622,389,418 confirmed cases worldwide and 6,548,492 deaths worldwide. These are WHO data. So if you look at those numbers, you will see that in the space of 1 month, we've had 10 million new cases worldwide, and we've had 36,000 more deaths worldwide in just 1 month. That is extremely disturbing. So let's talk about pandemic preparedness and response. Professor Akpan-Iquot has talked about this in Lagos. Looking at it from a worldwide perspective, in 2019, the world was unprepared for a pandemic. In 2022, we're still unprepared, in my opinion. So adequate global pandemic preparedness is vital before the next pandemic hits, because as most public health experts will agree, it is only a matter of time before we get another pandemic. So what are the key things that we have to do before the next pandemic hits? Early detection of outbreaks, prompt case definition, rapid mobilization of resources, and containment of the outbreak. These are the key things that are important in pandemic preparedness and response. You have to detect the outbreak early. You have to put out a case definition so people recognize the infection. And you have to mobilize resources and contain the outbreak in order to prevent it from becoming a pandemic. So strengthening national health surveillance systems is vital to preventing pandemic spread. If an infection starts in one part of the country, in order to prevent it from spreading all over the country, the national health surveillance system in that country has to be strong, effective, and working. Because a pandemic-capable pathogen, that is a pathogen that is infectious and can cause a pandemic. It only takes one plane flight for that pathogen to reach anywhere in the world, no matter where the outbreak starts. The outbreak can start in the jungles of South America, jungles of Southeast Asia, or even in Africa. It takes one plane flight for that pathogen to reach any major city in the world. So what does that mean? That means that a health threat anywhere, a health threat everywhere. Whatever threatens our health in one country threatens our health in all countries. That's how a pandemic operates. So what do we need to do? We need to develop and deploy effective outbreak management and public health emergency response programs in order to prevent future pandemics. So in this world, we are all in it together. Pathogens do not respect borders. We have to look at this on a global perspective. What Lagos State has done in the COVID pandemic is excellent, is admirable, is laudable, but that has to be replicated all over the world in order to prevent future pandemics. So the World Health Organization's rapid response is well documented. So just to briefly talk about this, on December 30th, 2019, the WHO received the first alerts of pneumonia of unknown etiology in Wuhan, China. They asked the Chinese officials for further information. On January 1st, 2020, WHO activated its incident management system. Professor Abayomi talked about the incident management system in Lagos State. So the WHO activated its incident management system worldwide. So on January 5th, 2020, WHO issued a global alert to member states. All member states notified of this outbreak in Wuhan, China. So between January 10th, January 12th, WHO published a comprehensive package of technical assistance for countries. So this rapid response is extensive. So I don't have time to go over it here, but that's the reference at the bottom of the page. You can look it up yourself and look at how WHO responded to the outbreak. So what about pandemic preparedness in Nigeria as a whole? Professor Abayomi talked about Lagos, but there's more to Nigeria than Lagos. The federal agency tasked with the job of pandemic preparedness is the Nigerian Center for Disease Control, NCDC, and is the National Public Health Institute for Nigeria, and is modeled after the US Centers for Disease Control and Prevention. So the NCDC is a federal government agency under the Federal Ministry of Health that is tasked with outbreak detection and containment. That is its job. So it was established in 2011, and it was put together from units of the Federal Ministry of Health Epidemiology Division, Avian Influenza Project, and the Nigerian Field Epidemiology and Laboratory Training Program. So all those pieces came together to form the NCDC. And the NCDC has played a major role in containing the Lassa fever, yellow fever, monkeypox, cholera, meningitis serogroup C, and Ebola virus outbreaks, and is also working hard on the COVID-19 outbreak in Nigeria. So to give us a few numbers, as of September 10, 2022, the NCDC says that there have been 264,014 confirmed cases of COVID-19 in Nigeria and 3,148 deaths. That was a month ago. The references are below and you can review the data at your leisure. Now, there are some problems and solutions in the pandemic response. First of all, the pandemic continues because there's emergence of new variants. There's ongoing transmission, there's ongoing replication, there's ongoing mutation, therefore there's continued emergence of new variants. These new variants are more infectious than the previous ones. That is a very disturbing trend. The new Omicron subvariants are BA4 and BA5. And this can partially evade the immunity generated by prior infection and caused by the older variants. I'm sorry to inform you that these new subvariants, they're old now. We have newer subvariants. We have BQ1 and BQ1.1. We have BA2.75. In fact, the surge that is being observed in Europe now is caused by one of these new subvariants. And because of the previous trend, once there's a surge in Europe, the surge is going to be manifest in other parts of the world, in the US, in Africa, and Asia. So this is a kind of heads up for us in various parts of the world. There is an ongoing surge in Europe, which means that the surge is probably going to happen in other parts of the world. The other important point to note is that the antibodies are produced against the spike protein. There's a part of the viral entity that's called the spike protein. And that part of the viral entity is subject to frequent mutation. Virologists will tell us more about this, but that part of the virus mutates. Every time the virus replicates, there's some mutation, there's a change. And because the vaccine is targeting that spike protein, every time the spike protein changes, it makes the vaccine less effective against the virus. So vaccine-induced immunity is less protective against the newer variants, the BA4 and BA5. And it is thought that even the newest ones will be even more or even less susceptible to vaccine-induced immunity. So Moderna and Pfizer have come out with a new boosted COVID-19 vaccine that targets BA4 and BA5 subvariants, and that is being administered in various parts of the world now. But what do we need? We need a stable viral protein target for vaccine production. A viral protein target that does not change, that is not subject to mutation. And then if we make a vaccine against that viral protein target, that means that vaccine will be durable and it will be effective for a long time to come. That project is being undertaken now by CEPI, the Coalition for Epidemic Preparedness Innovation. It's an innovative organization that is working on making a vaccine that will be durable so that we don't have to be getting a new vaccine every few months. So when produced, such a universal COVID-19 vaccine will be effective against newly emerging variants as well as the previous ones. That will be a very good development. So the other important problem in this pandemic is that there has been inequitable COVID-19 vaccine deployment. Many countries of the world do not have sufficient doses of COVID vaccine. Many countries are unable to vaccinate their populations adequately. And because of that, that leads to persistence of the pandemic. So what do we need? What's the solution to that? We need to deploy the COVID-19 vaccine in all areas of the world, not just in the resource-rich countries of the world, because viruses do not respect borders. So let's talk about the vaccines. The mRNA COVID-19 vaccine made by Pfizer and made by Moderna. Let's talk about the mechanism of action briefly. The mRNA vaccine contains a messenger RNA segment that encodes for a piece of the spike protein on the viral particle that is used to attach to the human cell prior to infection. So let's break this down. There's a part of the virus that's called the spike protein, and that's what the virus uses to attach to the human cell. So that mRNA segment is the genetic component that encodes for that piece of protein. So when that mRNA molecule, the mRNA molecule is encased in a lipid bubble. See, this vaccine technology is ingenious, and it's been under development for many years, and it just happens to be completed just when the COVID pandemic started. That's an act of God. So the vaccine contains mRNA molecules encased in lipid bubbles. When that is injected into the arm, the bubble attaches to the muscle cell membrane and gets absorbed into the cell. And then that mRNA segment programs the cell machinery to start producing spike protein, just like the virus. So the spike protein is then released into the blood, and the body's immune system recognizes it as foreign and starts producing antibodies against the spike protein. See, this is really great technology. So when the body makes anti-spike protein antibodies, these antibodies block the attachment of the viral particles to target cells, preventing them from getting infected. So this is basically how the mRNA vaccine works, and the reference below gives you all the details. What about the AstraZeneca and the Johnson & Johnson double-stranded DNA viral vector vaccines? How do they work? The double-stranded DNA vaccine encodes for the spike protein also. It's the same mechanism as mRNA, but this is a double-stranded DNA particle. And it's encased in a benign adenovirus. This is why it's different from mRNA. They put the spike protein in a benign adenovirus, an adenovirus that doesn't cause disease. And that is incorporated into the vaccine. So after injection to the arm of the host, the adenovirus infects the muscle cells, which makes them to produce and release spike protein. So the body's immune system recognizes the spike protein as a foreign body and starts producing antibodies against it. And again, the anti-spike protein antibodies attach to the viral spike protein and block its attachment to human cells, thus preventing infection. So what about vaccine development in the low and middle income countries? This is an important topic to consider and talk about, because most countries in Africa did not get or do not have adequate vaccine supply to vaccinate their population. And not just in Africa, in Southeast Asia, in South America, low and middle income countries. So global support is needed for local vaccine production in these areas. We need the world to support us producing our own vaccines in order to stop this pandemic. That is very important. But in order to do that, the companies, Moderna, Pfizer, AstraZeneca, they need to share their intellectual property in vaccine production. Unfortunately, this is not likely to happen. So low and middle income countries cannot afford to buy adequate vaccine doses. Therefore, the vaccination rates have been lower in these countries than in other countries. Outbreaks in these countries attract little global attention until the diseases reach Western shores. Case in point, the ongoing multinational outbreak of monkeypox. Monkeypox has been occurring in Africa for years, and the World community paid no attention to it. But now monkeypox has spread to Europe and America, and everybody's getting alarmed and taking notice. That's what happens all the time. African nations need to develop COVID vaccine producing capacity with or without help from Europe and America. This is very important because this will form the basis of future vaccine production capacity. If we learn now how to produce our own COVID vaccine, the next time a pandemic occurs, we'll be able to produce our own vaccine against that. We have to do this because the Western world will not give us adequate doses of vaccine, and we cannot afford to buy adequate doses of vaccine. The reference is below. So this is a slide that I just put in. It wasn't in the presentation when I made it last month. Moderna announced 2 days ago that it will provide up to 100 million doses of COVID-19 vaccines to target the new variants, the variants that are emerging, BA4, BA5, will provide 100 million doses. And these doses will be provided to Gavi, the Vaccine Alliance, to distribute these vaccines in the lower income countries by 2023, next year. It's not going to happen now, it's going to happen next year. So Moderna will supply these mRNA variant targeting shots to Gavi at the lowest of its tiered prices. The shots will be distributed to poor countries through the COVAX facility backed by the WHO to ensure vaccine equity around the world. Now, there is a problem with all this. I mean, this is great. Moderna should be lauded and congratulated for this donation, but this amount is totally insufficient to cover the needy masses in the low-income countries. Furthermore, I'm not sure that Nigeria qualifies as a low-income country. With all the oil money that we generate, I don't think the WHO is going to consider us to be a low-income country. So this donation is probably not going to affect us in Nigeria. Now, the Infectious Disease Society of America that I belong to and Folari belongs to put out some treatment guidelines for the COVID-19 pandemic. Because the infection is rapidly spreading and is causing a lot of deaths, the literature backing these guidelines is ongoing, it's living, it's being frequently updated, and it's evidence-based. Because things are rapidly changing, research is getting done on a daily basis. So this guidelines is being updated. And the guidelines support patients, clinicians in treatment and management decision-making. It also contains a detailed description of the background methods, evidence summary, and rationale. And that is the reference. I encourage those of you who are interested to look it up and use it in your day-to-day patient management. Now, there's a very important problem that has come up since the COVID-19 pandemic came up. And this problem is worldwide. And that is the problem of vaccine hesitancy and denial. If a vaccine can be very effective, can be 100% effective, but in a given population, the vaccine efficacy is limited by vaccine hesitancy and denial. What do we mean by that? The COVID-19 vaccine refusal is a problem in many countries of the world. In America, in Africa, in Asia, people are refusing to take the COVID vaccine for various reasons. And as a result of that, we cannot achieve herd immunity. It's impossible because enough people are not getting the vaccine, enough people are not getting immunized to achieve herd immunity. But significant sections of the population in many countries, these are called anti-vaxxers. They're refusing vaccines. They're refusing childhood vaccinations for their children. They're refusing measles vaccines. They're refusing polio vaccines. And that is a big problem. And that movement is spreading worldwide, spreading to even Africa. And it has led to the re-emergence of measles and polio in countries where this had been previously eradicated. To make matters worse, will smallpox reemerge next? Smallpox was eradicated in the world, but the virus has been recently isolated from sewage systems in New York City. That is a dangerous development. What about the next pandemic? What should we do? What shouldn't we do? Very important, we need to make public health policy decisions based on science, not politics. Science should be the basis of our health policy decisions. We should not listen to the politicians. They don't know anything about public health. Like I mentioned before, it is important to produce a vaccine quickly anytime there's an outbreak, anytime there's a pandemic. Now, I mentioned the Coalition for Epidemic Preparedness Innovation, CEPI. They have an initiative now to produce a vaccine against a pandemic within 100 days of outbreak. That is an ongoing effort, and that is a very laudable project, and I pray it succeeds. Now, we also need to avoid stigmatization of countries found to have new variants. You all remember when scientists in Botswana discovered the Omicron variant in late 2021. Immediately, countries in Europe and America put a ban, travel ban, on Botswana and South African countries. Now, this was totally uncalled for. Travel bans have no scientific basis and are of no benefit. So one thing that we must not do anytime a new variant is discovered, do not ban people from that part of the world to travel to your country. It does not help. Now let's talk about African countries. This is a very important aspect because how African countries coordinated their COVID-19 response. And this has been alluded to by Professor Abayomi as the response in Lagos. So all the 47 countries in the WHO African region instituted 3 levels of coordination: strategic, operational, and tactical. Strategic coordination, the country president oversaw the overall response. In Lagos, the Lagos state governor was the overall commander of their response. Operational coordination, provision of day-to-day technical and operational support to the in-country response team. The team has to get support on a daily basis. Technical information, operational support has to go to the team in order to make it function. Tactical coordination, that means you decentralize the coordination at local levels. And Professor Abayomi told us that the response to COVID in Lagos was not just in IDH, it was in the community, all the workers in the community. That is decentralization of coordination. So this coordinated response in Africa is thought to have slowed down the pandemic to some extent. And that is the reference below for you to look that up. So COVID-19 pandemic, what about the concept of lower mortality in Africa? What are the possible reasons why? A lot of research has gone into this and some reasons have been postulated. So the populational antibody testing indicates that there are similar rates of infection in Europe and Africa, similar rates of infection. So, but the far lower mortality in Africa, tenfold, the reasons are unclear, but it may include the following. 1, Africa's younger population with less comorbidity compared to Europe. Africans are much younger. Europe, we have a lot of older people. In Europe, you have a lot of people with comorbidity, heart disease, lung disease, diabetes, and things like that, making the mortality higher in Europe. Also, there's a postulation that prior exposure to other coronaviruses in the community in Africa could have provided some immunity against COVID-19 infection in Africa, because we do know that there are other coronaviruses in the community, in the environment, and because of their similar structure, they can engender some immunity, which is transferred to COVID, to the SARS coronavirus too. Then there's also the issue about incomplete data. because Africa has a far less testing capacity than Europe and America. So we may be missing some cases. People may get sick with mild cases and they don't go for treatment, they don't get diagnosed, or people may get very sick and stay home and die, and that is not counted. So there is the probability of incomplete data in Africa, making us feel that, Africa is much less hit. Then there is incorrect diagnosis and cause of death reporting. In Africa, a lot of people get sick with fever and they say, oh, it's malaria. So there may be incorrect diagnosis and incorrect cause of death reporting, leading to lower numbers for COVID-19. That's the reference right there below for you to review. Now, what about developing and strengthening our primary healthcare system in Africa? Professor Abayomi mentioned this too. A universal primary healthcare system will be a great resource in providing care in the event of an outbreak in any part of any nation. In the village, if there's an outbreak, the local health clinic will be the one that will recognize it and alert the rest of the country. We need to recruit and train prioritized healthcare workers. Primary healthcare workers will be the first to notice new and unusual signs and symptoms in the local populace and raise an alarm in the event of an outbreak. We need to establish effective surveillance and response systems. Epidemiologists and disease detectives should be sent from the National Public Health Institute to quickly liaise with and train the primary healthcare team at ground zero.
Olaji,
Yes.
I appreciate your lectures. Everybody's getting...
Two more slides. Two more slides.
Please, okay?
Okay, I'm finishing up. All right, so the NCDC and the RTSL partnership, this is very important. Nigeria needs outside help and coordination with foreign partners in order to counter this and future pandemics. There is an entity called the Resolve to Save Lives, and this partnered with the NCDC, and that is providing adequate help to Nigeria as we speak. So what are the summary? What are the lessons we need to learn? Number one, we need to encourage pandemic preparedness at local, national, and global levels. We need early warning systems and stations. We need to strengthen vaccine production platforms. We need to improve vaccine education and acceptance. We need to ensure equitable vaccine distribution and deployment. And we need to follow the science and not the politics. So this has been a global view of the COVID-19 pandemic. Thank you very much.
Well, thank you very much. I'm so sorry. It's just the timing, We would love to listen to your lecture. You can do us a favor by dropping your slides on the Dropbox or whatever. There's somewhere. There's actually supposed to be some slide package, that is going to be distributed later. So we'll move forward. But no time for questions now. Maybe later in the day we can ask questions. But the last speaker before lunch, I've warned him that it needs to be like 10 minutes. And I can bully him. He's my younger brother. Dr. Akase is the professor or whatever. I promoted him. In charge of infectious disease at the College of Medicine, Luth. He's going to just talk to us briefly about the experience in Luth. After that, we are going for lunch, and we have lunch for a little while before the professor, the VC, speaks about monkeypox, and Dr. Ikeja will run it up.